Hi, my name is Kim Eagle from the University of Michigan. I'm the editor of ACC.21, and we're here at the ACC.21 virtual annual scientific sessions covering the major clinical trials. Today's coverage is on Sunday, May 16th. I'm joined by two outstanding cardiovascular specialists, Payal Kohli from the University of Colorado and Deepak Bhatt from the Brigham and Women's Hospital in Boston. There are 6 trials today that we thought we would bring to you. And we're going to start with one called Flower MI. Deepak?
Well, this is really a terrific trial, important question, great acronym, nice peaceful acronym, Flower. And Kim, I'll just say, I really appreciate when you post on your Twitter feed various pictures of flowers. It starts my day off in a very peaceful way. But what this was a trial of STEMI patients. They all got culprit PCI and then had another 50% or more lesion in another major artery, and were randomized to either doing it the usual way, based on angio, you decide whether to treat or not treat that other lesion, or to use FFR to guide that therapy. The presumption being FFR guidance would make things more precise and should improve outcomes. But I guess maybe somewhat surprisingly, good old angio-based approach seemed to work as well as FFR. The overall rate of MACE, I'll say, was kind of low, but at least within the statistical power here, it seemed like just using the angio to decide whether to treat that non-culprit lesion in the STEMI patient was as good as using FFR, and a little bit cheaper as well to just do it that way. So it's a win for good old angio.
I was surprised by this result. I was sure that FAME would dominate in this situation, but it didn't. I was curious, then the authors at the end of their presentation said, we favor staged PCI of the non-culprit lesion. Your comments to that?
Well, I mean, that's what most operators do as well. That is, if somebody's got an occluded RCA, STEMI, just open that up. And if they've got a tight mid LAD, probably better to do that as a staged procedure. Operator / patient / healthcare system's choice, either later during that index hospitalization or bring them back, later on in the month. This is especially important if the creatinine's high or it's Saturday night and team's tired. So for a variety of reasons, I think in general, that's better. On the other hand, if that second lesion's a slam dunk, OM1 mid lesion, and you think you can do it all then and there, I don't think there's really a penalty for doing that if you're quite confident you're not going to run into a procedural complication.
Excellent. Thank you, Deepak. Of course, in the COVID pandemic, we're looking for solutions, and DARE 19 is a very interesting trial. Payal, tell our learning audience about this one.
I'll also say I really do like the name of this one because it dared to be bold during the COVID-19 pandemic. So this is a trial of an SGLT2 inhibitor during acute illness with COVID-19 in patients who had cardiometabolic risk factors. And these were not critically ill patients, but patients that were hospitalized with COVID-19. And essentially they looked at 2 dual primary endpoints. The first was a prevention endpoint that looked at time to death or organ failure. And the second was a recovery endpoint that looked at discharge from hospitalizations and clinical status and so on and so forth. And the trial overall was negative. So neither dual primary endpoint was able to achieve statistical significance. However, numerically, the number of events with dapagliflozin was lower than it was with placebo in these patients. So I thought this trial was really interesting, firstly, because it was done in the midst of a global pandemic in a patient population that was affected by the global pandemic. Secondly, I think it really sort of raised the issue of using these types of therapies during the acute illness and during conditions like COVID-19, ARDS, acute kidney injury and such, really opened the door for us to start using more upfront therapies to see if we can modify the illness early. And then finally, I do think it reassured a lot of us that it is safe to continue these SGLT2 inhibitors in our COVID-19 patients. In fact, the rate of renal endpoints was actually slightly lower in the DAPA arm than it was in the placebo arm.
Right. I think you're right. I thought the study ended up being a little underpowered, but the safety factor is very reassuring to us, and hopefully will give us some confidence that we can continue these agents. We sort of went through this with ACEs and ARBs as well, and I think this gives us confidence. There's another COVID trial today called ACTION. Deepak, tell us about that trial.
Yeah, this is a great trial, really important question. I mean, there's been all sorts of stuff going on with COVID, people just adopting practices without data, small trials leading to rapid shifts in data in practice without necessarily robust data. So this is a terrific trial. Took patients and randomized them to either the standard of care within hospital prophylactic dose anticoagulation, if they've been hospitalized with COVID, versus therapeutic anticoagulation without there being an independent indication for it. And that was in-hospital rivaroxaban for stable patients, in-hospital enoxaparin for unstable patients, and then rivaroxaban for 30 days afterwards. And the bottom line was there was no advantage to therapeutic anticoagulation as a matter of routine versus appropriate guideline-based in-hospital prophylactic dose anticoagulation in these COVID positive inpatients. So this is huge because there are a lot of doctors, a lot of hospitals, a lot of healthcare systems that are just routinely anticoagulating all their COVID positive inpatients. It makes sense biologically because COVID causes inflammation and thrombosis. I get it, but this trial once again shows why we need randomized clinical trial data before just doing what seems to make biological sense. Because obviously with full dose anticoagulation, you get bleeding, and sick inpatients, like COVID inpatients that are sick, are going to be potentially even more susceptible to bleeding and bleeding complications. So bottom line, prophylactic anticoagulation of the inpatient is appropriate, as is the current standard of care. Therapeutic anticoagulation, just because they have COVID, isn't the right thing to do unless they have an independent anticoagulation indication. Then, of course, do it.
It's such a great example of how early case series of nasty thrombotic complications get reported in major journals, as they should, because we're learning about an illness and its effects. But then when we step back and do the right science, we learn things that are really important to practice. And I do think this is a practice-changing trial. It's going to pull us back a little bit from just assuming that full dose anticoagulation is the way to go. And you just have to applaud these investigators to kind of put this trial together during essentially a war zone-like atmosphere out there.
Yeah, agree. Really, kudos to the investigators. Just to quickly point out to the audience, there are other ongoing trials, other completed trials. Some have been reported in press releases. So, there will be more data coming out on this topic, but for the time being, I'd say hold the course. And unless the patient's in a trial, stick with prophylactic anticoagulation unless there's an independent indication to anticoagulate separate from COVID.
Great. Payal, there's a trial called Rehab HF that really looks at how do we deal with frail elderly patients with heart failure and manage them the best way we know how. Tell us about this interesting trial.
This was a randomized trial of elderly patients with acute decompensated heart failure. As you pointed out, 97% of them frail, 14 to 16% had falls within the past 3 months. And it looked at a tailored intervention with 4 different domains as compared to standard, rehab therapy that we often prescribe after heart failure admission. And what they found was that the primary endpoint, which was a short physical performance battery, which is essentially a score of their physical function, was substantially improved and uniform across all the subgroups. In fact, they even found improvement in their 6-minute walk test, in their quality of life, in their frailty index, and even in their depression. So this really, to me, attests that non-pharmacologic interventions that are targeted and tailored can have a profound impact on patient outcomes. And these are high-risk patients that we're talking about because they had over 10% of them die within the 6-month follow-up. So I think a really important advance in our geriatric population, which we often think about just adding more and more pills to their pill box, but really this tells us to think beyond the pill box and to think to our toolbox instead.
I agree with your analysis. I was disappointed that the rehospitalization rate and mortality did not show a trend toward favorability. And it just tells us just how much of an uphill struggle we have with this kind of a patient population. Any thoughts about that, Payal?
I think the timeline was a little short, Kim, to really see the impact of this type of intervention. I'm hopeful and optimistic that perhaps if we had followed longer with this intervention ongoing, we may have seen those curves start to diverge. But to your point, it is very challenging in this population. And most of them were managed, obviously, very well medically. Right.
They were really well managed. It'll be interesting to see in the longer term follow-up what happens here, but certainly a trial that I think could be the beginning of a paradigm shift in terms of how we view helping patients in the hospital and out of hospital deal with tough heart failure and frailty. Let's move to a very interesting paper that I found to be potentially practice changing called Host Exam. Deepak?
Yeah, I think this is a really interesting trial, maybe in part because it found what I sort of believe, but I think it is a really well done study, a bit over 5,000 patients. And the target population were patients who had PCI. They were on DAP, dual antiplatelet therapy, for about 6 to 18 months or so, didn't have any sort of badness occur then, and then are randomized to either aspirin for 2 years or clopidogrel for 2 years, basically trying to figure out which is better in that therapy in that scenario as far as antiplatelet monotherapy. And the results were really quite striking. Actually, I thought the trial was going to be underpowered to show anything, but it did end up showing a significant benefit in the primary outcome, which was a mixture of ischemic and bleeding events in favor of clopidogrel. So clopidogrel beat aspirin. And even more interesting, it beat it separately, both for the thrombotic composite outcome and the bleeding outcome. So a double win with statistical significance for both those types of endpoints. So to me, it's really an important and well done study. And it buttresses an old study that I think a lot of doctors have forgotten about or kind of ignored, the Capri trial, which wasn't stented patients, but was high risk secondary prevention, where clopidogrel monotherapy beat aspirin monotherapy with a significant reduction in ischemic events. And we published this in the secondary analysis, a significant reduction in hospitalization for GI bleeding. So there was a double win as well. At the time, people said, oh, clopidogrel, it's super expensive. We're not going to use it. The benefit wasn't so much greater than aspirin. But now it's generic, not as cheap as aspirin, even as a generic, but we have this trial that essentially corroborates the message from Capri, that is, clopidogrel is a better antiplatelet than aspirin.
Absolutely. I think this is a really important trial, and I think it's going to have an immediate impact on our secondary prevention in patients who've had PCI. So let's finish with this very interesting paper called, okay, Deepak, you got it back.
No, just one quick thing, just to, yeah, I gave a very pro, but just to, it was relatively underpowered, even though it ended up being positive. It was an open label design. There's always some potential, for bias creeping in. Having said that, I don't immediately see how those are deal breakers here.
Yeah, I think the fact that the bleeding endpoint was favored as well as the thrombotic endpoint, and with the drug being potentially more available in terms of price, I have a feeling this may start to change our thinking a bit. So let's finish in the area of hypertension with a trial called Radiance HTN Trio. Payal?
Yes, Kim. So I just smile because I'm surprised we're still talking about renal denervation. I feel like it's been going on since I can remember when I was a resident. But essentially, this was a trial of ultrasound-guided renal denervation in patients with resistant hypertension, meaning that they required at least 3 medications. And the medications being used were, your ARB, your calcium channel blocker, and your thiazide diuretic. A few of them were on beta blockers because of a different indication like heart failure. And what they did is ultrasound-guided renal denervation. They did have a sham procedure arm as well. So there was a group, the placebo group got the sham procedure, and they saw a reduction in the blood pressure of 4.5 millimeters of mercury, more than the sham group. So total of 8 millimeters of mercury, but 4.5 above the sham group. And they saw it for the ambulatory blood pressure, the 24-hour blood pressure, the nighttime blood pressure. So, the numbers, as we always talk about in these hypertension trials, not always so impressive in terms of absolute reduction in blood pressure. But it does sort of prove the principle, perhaps, that renal denervation does help with resistant hypertension. I will say that most of these patients were not on an MRA, which I usually start for a lot of my resistant hypertensive. So I think that's a little bit of a limitation of the study. I also don't know what the durability of this effect is over time, as we've seen with other renal denervation studies.
Excellent. I'm just like you. I thought after simplicity that this strategy was gone. And now it's back, and perhaps it will find a role in patients who fail the MRA antagonists, as you pointed out. Any comments, Deepak?
I think Payal's summary is really spot on. I mean, it's proof of concept again that renal denervation really does work, but at least with current technology, it is a modest effect size. It's true that the degree of effect, if you extrapolate it to populations and it were durable, should reduce MI and stroke and heart failure and that sort of thing. But that's not directly been proved with renal denervation yet. So I think we need larger studies and longer term studies and refinements in the technology to get a more robust effect. And finally, Payal's point is key about appropriate medical therapy. I mean, if patients have resistant hypertension, really their doc should at least try them on an MRA. They're cheap, they're easy. If you're careful with the dosing, the side effects aren't that bad. And a lot of times I've seen, especially in the obese hypertensive patient, their resistant or seemingly resistant hypertension melt away once they're started on some spironolactone. So something to consider.
Excellent. Well, 6 great trials that were presented today. We're happy to bring these to you. I want to thank you, Deepak and Payal, for your excellent analysis. Kim Eagle for ACC.org, and I'm out.